All right. Good evening, ladies and gentlemen. A very warm welcome to you. I'm Devana Gupta, Client Success Manager at Cartula Health, and this is the fifth session in our webinar series. Today's topic is gestational diabetes. To introduce us, Cartula Health India is a part of the Australian owned company, Cartula International. We're committed towards bringing better healthcare to India. Our apps are successfully launched and freely downloadable on the Google Play Store, a telemedicine application that connects doctors and patients, and Cartula Janani, a free pregnancy and childbirth tracker. And for today's session, we bring to you Dr. Haleema Yezdani. She's a general physician and diabetologist. She has more than 19 years of experience. She's received multiple awards and recognition for her work in telemedicine. I now request her to begin the presentation. Ma'am, please begin the presentation.
Hi everyone. Thank you, Devina, for the introduction. I hope I'm clear. Am I audible?
Yes, ma'am. Absolutely.
Thank you, everyone, for this. For coming in on a Saturday afternoon. See, basically, the reason why we chose this particular topic is that this is one of the few subjects or one of the few illnesses wherein patient education is the key. Patient education is the key for managing the problem as for preventing the particular onset of this particular disease. So, what I mean by saying these two lines, let us just go further in the presentation and everything will unwrap itself slowly. The next slide, please. Okay, so better understanding, I have divided the entire presentation into the following headings. We'll first go to the introduction of gestational diabetes, the signs and symptoms of the illness, how can it be prevented, the investigations required for the particular problem, the treatment and conclusion or the take-home message, which is very important when we are addressing a patient gathering or when we are addressing people about a particular subject or particular ailment. The next slide. Okay, so gestational diabetes, or I think going down further, we'll be calling it as GDM, is defined as high blood sugar or glucose intolerance in a pregnant lady who has never been diagnosed with diabetes earlier. It is very important to add the line that she has never been diagnosed with diabetes earlier. This is what differentiates between type 2 diabetes and gestational diabetes mellitus or GDM. There's a thin line between the two, the time of onset and the history of diabetes prior to gestation. These two make a huge difference in diagnosing gestational diabetes mellitus. Okay, this usually manifests, as I told you, in the second or the third trimester of pregnancy. It is difficult to differentiate between type 2 DM as the onset, it happens in young adults, which is quite a common phenomenon of late. As most of you must have heard or seen in patients and as well as your friends and family that type 2 diabetes is setting in very early these days. Let us blame it on the lifestyle which is going on of late, or the stress, or the type of jobs that we are all involved in. Type 2 diabetes is coming in as early as the late 20s, or even I have seen patients around 20 to 25 years who are suffering from type 2 diabetes. Okay, so how do we actually, what is basically the key factor of gestational diabetes? Early detection is very important in the interest of both the mother and the fetus. As gestational diabetes not only harms the mother, it not only harms the lady who is having it, it also can be gruesome for the child in her. So it's very important to detect and manage it at the early stage. Next slide, please. Next slide, Sumit. See, as you can see here, children born to diabetic mother, unfortunately, they're 8 times more prone to develop diabetes during their adulthood. They might not have type 1 diabetes at the time of birth. They might not have any kind of signs and symptoms of diabetes at the time of birth, but definitely they're 8 times more likely than the other normal adults who are born to a normal mother to develop type 2 diabetes in their adulthood or early teens. Approximately 50% of the ladies get diabetic with type 2 almost within 5 years of gestational diabetes if proper. This is the game changer. If a lady who has had gestational diabetes does not get converted to type 2 diabetes in 5 years, it is an achievement for the diabetologist as well as the gynecologist. Patient education, patient compliance is the key for management in this particular aspect. Next slide, please. What exactly happens is, gestational diabetes usually resolves after the childbirth. Usually, as you can, as most of you must have heard, that the lady will be heavily diabetic in the last trimester of pregnancy or the second trimester of pregnancy, and it is like a magic, change. Immediately after the birth of the child, within few hours, the sugars get to normal. As soon as the child is delivered out of the body, the sugars get to normal. So, what could be the causative factor for developing a gestational diabetes mellitus? We can blame it on increasing level of placental hormones throughout the pregnancy. Increasing insulin resistance can be a primary cause of GDM. And as I told earlier, it is most commonly seen during the time when all these things are starting up. Right? We're talking about the second and third trimester of pregnancy. If
Dr. Halima?
Hello? Yeah, I don't know. There's some network issue. Fine. Okay, so it usually, as I told you, like it is seen in the second and the third trimester of pregnancy. If blood glucose levels are high in the first trimester, at this time, please consider type 2 diabetes. It's very important to consider type 2 diabetes at this level.
Hi, we are having a network issue. We'll just be back in a moment.
Hello? Hello? Can
Yes,
you all
ma'am. Are
hear
you
me now?
connected?
Yeah, I'm so sorry. Yeah, I
No
don't know
worries,
what's
ma'am.
happening. Right.
Please
Okay.
go ahead.
Right. The next slide, please. The next slide, Sumit. Okay. The previous one, I think you missed one. Yeah. So, what are the risk factors which actually attribute to this particular ailment? First of all, the maternal age. At this time, I would like to mention the ideal maternal age for first pregnancy should be not more than 30. If a lady conceived for the first time after 30, she is at a high risk for getting gestational diabetes mellitus. Secondly, the BMI, previous history of impaired glucose tolerance or GDM during her previous deliveries, if it is a second pregnancy, previous, abnormal deliveries like a big baby or any kind of obstruction during her labor, previous fetal loss is also a major risk factor in developing the second gestational diabetes. Next slide, please. Next slide. Yeah. So first degree related with diabetes, like could be her mother, her father, her, the first was the sibling. Anyone is diabetic. There's high risk for the lady to get into type 2 or gestational diabetes mellitus. Any gynecological conditions which are pre-existing, like polycystic ovary, that is a huge important condition that can precipitate this kind of ailment, and any fibroid which is been there for a long time and causing a lot of stress in the body, and pre-existing type 2, of course. If there's a pre-existing type 2 diabetes, it is usually carried on with the pregnancy, gets worse, and requires quite aggressive management. Next slide. Next slide, Sumit. Right. So when we're talking about advanced maternal age, we're talking about pregnancy of the first pregnancy, the primary gravida of around 30 years or more. And the risk of miscarriage gets high, genetic abnormalities get high, pregnancy-related complications like gestational diabetes gets high. And this is quite a very significant factor for the lady to develop gestational diabetes mellitus. Next, please. BMI, if a lady who's already having a BMI of more than 30, she's very prone to go in for gestational diabetes mellitus or impaired glucose tolerance during her pregnancy. Next, please. Next slide. A big baby. If the lady has delivered a big baby earlier, big baby as in I mean more than 4 kgs or 3.5 to 4 kgs, she definitely is prone to develop gestational diabetes in the next pregnancy. Polycystic ovary with hormonal changes, with active manifestation of polycystic ovarian syndrome is a high reason for the lady to get into body to get into stress and to have a lot of hormonal imbalance precipitating gestational diabetes. Next, please. Race. Strange enough, yes, gestational diabetes is very common in different kind of ethnicity, and this plays a huge important role in the precipitation of gestational diabetes mellitus. So, any kind of American Indian lady, an Asian American Asian lady, American lady, unfortunately, Hispanic ladies, all these people are they have a very high risk of developing gestational diabetes mellitus. The reason is yet to be investigated, but during studies, it has been found that these ladies are more prone for gestational diabetes than their other counterparts. Next slide. Okay, so once now we know the risk factors, now we know what exactly gestational diabetes mellitus is. The first thing after this we would like to know is what are the signs and symptoms. Very important thing, this could be totally asymptomatic. Hence, it requires very high degree of suspicion to diagnose and treat it at the early stage before the maternal or the child complications can occur. So other symptoms which are actually most oftenly present yet missed and attributed to pregnancy is the lady may feel tired most of the time. People may think that this is because of the pregnancy related stress, excessive thirst, excessive urination, excessive hunger, very dominant nausea. So as you can see, all these also can happen in normal pregnancy, but this requires very high index of suspicion, very high knowledge about the ailment to go ahead and investigate the lady further for gestational diabetes mellitus. So do not miss these kind of symptoms, especially patient education at this time is very important, because any lady who is pregnant and suffering from these kind of ailments has to go and get herself tested for diabetes mellitus, and of course it should not be late. Next, please. Next slide. Other symptoms could also be blurred vision on and off, as in there could be she could be totally normal and suddenly she starts getting blurred vision or impaired sudden onset severe dizziness and weakness, repeated vaginal infection, vaginal itching, irritation or infection, repeated urinary infections which is like resolving and maybe she recurs or she gets back to the doctor after a week or 10 days with another bout of infection. So these things should not be neglected, and in this case high index of suspicion and high index of investigation has to be done. Unusually big baby bump, as in if you see a lady who was pregnant maybe into her second trimester, but the baby bump that is seen is little not corresponding to the age of the fetus, which is seen or during her as per her history. At this time, please go in and check for diabetes mellitus. Next, please. Next slide, please. So now, how do we come to the prevention? How is it that, of late I have seen many ladies who are basically getting into this problem of GDM, and though it is very simple to prevent onset of GDM in pregnant ladies. First and foremost, eat healthy. Even before you plan to conceive, I'm sure most of the ladies here planned before conceiving. If so, please, especially if you have a strong family history of diabetes, make sure that you follow a very healthy diet. By healthy diet, I mean do not do no what skipping meals, or do not kind of starve yourself or going for crash diets. eat healthy, eat at a normal time, and have more of green leafy vegetables, have more of fruits with low glycemic index, and have a very balanced meal to maintain yourself. And walking during the pregnancy, if permitted, around 30 to 45 minutes of day will work like magic. Follow a disciplined life, eat on time, and ensure at least 8 hours of undisturbed sleep. And follow up with your gynecologist regularly for possibility of GDM. And get it diagnosed at the early stage so that the management can be done at the earliest before it can harm the child. Next, please. Next slide. So, how do we investigate? First of all, as I told you, high index of suspicion is required to diagnose it early and to prevent the complications. Initially, a glucose challenge test is done at the onset of the second trimester, wherein the lady will be asked to drink a syrupy glucose solution, and 1 hour later, blood test will be done. A blood sugar level of 190 milligram per deciliter or 10.6 millimole is considered as a lady having gestational diabetes. Even up to 140, 150 will not take it as diabetes after the glucose tolerance test. Blood sugar level higher than 190 is considered as positive for GDM. Next, please. Next slide. As I told you, the first test is glucose tolerance test, and the second test, HbA1c. This is called as glycosylated hemoglobin. This test is done frequently in combination with home glucose monitoring, like the general monitoring what we do, which ensures early detection and proper management of diabetes mellitus. So it's very important for all these tests to be done in combination with each other. First, we go ahead with the oral glucose tolerance test, followed by glycosylated hemoglobin and urine ketones. Why are the urine ketones checked? These ensure adequate intake and rules out any starvation ketosis. What happens if urine ketone is positive? There can be two things. The lady is not having proper diet. She is not maintaining the diet required for a pregnant lady at this stage, or simply her GDM is getting worse. So urine ketones will have to be checked daily in some people, and with early morning first sample is ideally taken for checking the urine ketones. Next, please. Next slide. What is a CGM? CGM is a very advanced technology nowadays wherein we can monitor the glucose continuously. It is not required that you go ahead and keep pricking your body every 8 hours or every 3 hours to check for your blood sugar. This is a monitor which is fitted in the hand or in one part of the body. It's a sensor which will kind of keep checking your sugars regularly. So, why is it required for a person or a lady with diabetes or a GDM to get her sugar tested so regularly to prevent any kind of episodes of hypo or hyperglycemia? Because as compared to their normal diabetic counterparts, gestational diabetes are prone for severe hypo or hyperglycemic episodes, which can be harmful for the mother as well as the baby. And CGM can also can also help in early diagnosis of DKA, that is diabetic ketoacidosis, which can actually be a life-threatening event in the pregnant lady. And it can actually kill the lack of coordination between HbA1c and HGT. Sometimes what happens, your HbA1c will show maybe 10.6 or maybe 11 or 12, but your home glucometer will be showing the stat reading with which the lady will come to the doctor can be showing 110 or 120. At this time, the doctor is confused to increase the dose of insulin or to go ahead and continue the same dose, which can this decision can be life changing for the lady as well as the growing child. At this stage, the CGM or the continuous glucose monitoring definitely helps in wonders. So in this, the doctor can get a reading, the average of all the reading over 24 hours and take a decision whether to change or to keep the dose at the same level, and it causes reduced incidence of infant birth weight changes. So CGM is definitely very important if a lady has uncontrolled GDM. Next, please. Next slide. The other group of investigations, along with diagnosis of GDM, are something to understand if the lady is getting complicated or if there are any other issues occurring along with gestational diabetes. So kidneys have to be monitored more or less very rampantly, and renal function tests like urea, creatinine have to be done. Monthly ocular examination to see the retina is very important if sugar is uncontrolled. Even otherwise, I usually recommend my patients to get a monthly ocular examination, especially in pregnancy. Anti-insulin antibody, anti-GAD antibody, all these has to be done very early in pregnancy to diagnose any kind of insulin resistance or any other problem apart from pregnancy causing diabetes. Follow-up of glucose tolerance tests in the next 2 months or so is also highly recommended. Next, please. Next slide. Yeah. So now we went through the maternal investigations, which has to be done in the GDM. What about the fetus? So once a lady is pregnant and she's diabetic, what kind of fetal investigations are very important? First, regular fetal ultrasound. This is required frequently in mothers with GDM because of growth discrepancies and to check for congenital anomalies. It is a very good gateway to measure the fetal development and to check for hydramnios. Hydramnios is a condition wherein you can see the liquid over there above the baby that can increase grossly in diabetic mothers, and this can be prevented and this can be controlled if we diagnose it early. So, as compared to the normal counterparts, mothers with GDM require much more extensive fetal ultrasounds and fetal investigations for evaluation of fetal well-being. Next, please. Next slide. Okay, that is about non-invasive, but at times we may need to do amniocentesis, which is nowadays it is not done because our radiological examination has really reached the zenith and we can definitely view the fetus through and through now. But amniocentesis in uncontrolled diabetes is definitely important. Amniocentesis is nothing but removal of fluid from the fetal sac to assess the growth of the child. It is by doing a lecithin to sphingomyelin ratio. Lecithin and sphingomyelin, these are things present in the amniotic fluid, which is tested with by taking a syringe and aspirating the fluid. And this is done just to assess the growth of the fetus. It is done. It is whether the spinal growth and the growth of the fetus is adequate for the age or not. Next, please. And more commonly done in diabetic mothers. Next slide. So, what is the treatment? The treatment consists of, I would say, two major aspects. One is lifestyle modification. This can be possible in early stages of GDM, and secondly, medication. Medication is definitely very important if it is diagnosed a little later and if the sugars are uncontrolled. So, we'll go much in detail about that. Next, please. Next slide. Okay, by lifestyle modification, a very important thing at this point is nutrition. This plays a huge role in in reducing the blood sugar in patients with GDM as well as in type 2 diabetes. It is not enough if you just eat. It is very important to eat right. Taking the right amount, the correct nutrients plays a very vital role in management of GDM. This is nothing but medical nutrition therapy. Nutrition therapy is also a part of treatment, a part of management in diabetes, type 2 diabetes, and gestational diabetes in particular. It's very important for the ladies to have food which are having a low glycemic index and which are very limited in all refined carbohydrates and sweets, which are very high on fiber, and avoid all kind of fats. Moderate amount of lean protein is also highly recommended. So as you know, nowadays there are many kind of modified rice. There is modified other kind of diets. You can include millets, you can include oats. So all these things are very low in their calories, very low in the glycemic index, easily digestible, and definitely helps the management of sugars at a long run. So I would recommend all the ladies who want to conceive, as well as who are already pregnant, to modify the diet in the right way. Next, please. Next slide. The second thing, stay active. It is very important for a pregnant lady, especially with diabetes, to be active. By active, I mean do not strain yourself, do not go in for aggressive gymming, do not go in for rash exercises or weightlifting, weight training. No, simple household activities, simple activities like walking and just simple stretches on and off. And even if you take rest, just keep breaks in between. Get up, maybe going for a walk 10 or 15 minutes, in every 2 3 hours interval. Make sure you walk at least for 10 to 15 minutes, and in that way your circulation as well as blood sugar is under control. So stay active most of the time and eat right. These two are very, very important. Next, please. Avoid stress. This is a stage wherein the lady is stressed in every way. When you start imagining things, when you start, having hormonal imbalances, to add on, if she's diabetic, then stress plays a very huge role. At this point, I would say that avoid stress. By avoid stress, do not think about it. Try to relax yourself. Try doing what you like to do. Try to, maybe if you like to read a book, like to listen to music, or even doing yoga or breathing exercises definitely helps to de-stress a person. um, do not kind of become finicky. I know the hormones will play a really bad role at this time. Try to remain, keep your calm. Try to engage in social activities, talk to people, and do not vent yourself. Do not, like, kind of clog yourself. Talk to people if you are friendly with people around. Talk to them, let them know what you're feeling, and try to relax by doing what you like to do. That is the very important thing for de-stressing. Next, please. Next slide. Next slide. Okay, so now we finish with the lifestyle modification. The previous slides, the previous slide, I think you slipped that. Yeah. So now we come to the medical management or the medication. Two important medications in gestational diabetes is metformin and insulin. These two are very important in managing the blood sugar. Other oral hypoglycemics can have rapid side effects. So basically, we think of either metformin or insulin dispensing. Insulin is basically considered the first line of management. And if insulin requirement gets very high at a particular point, then metformin can be considered, especially after 20 weeks of pregnancy. Hypoglycemia and weight gain, though, are much lesser in metformin, but still we consider insulin as a primary management in management of GTM as compared to metformin. Next, please. Next slide. Okay, so treatment aspect, the maximum dose of metformin that we give is around 2 grams per day. If 2 hour ppbs is more than 200, then usually it is the other way around. What we do is, if insulin levels go very high after we start insulin, then we add on metformin as to maximum of 2 grams per day. If requirement of, as I told you, insulin increases, then metformin is added. And if there is a lady on insulin therapy for the first time, please educate her on hypoglycemia, because yes, this happens, and this is where CGM plays a very important role. When we're having a sensor attached to the body, for a lady with first time insulin therapy, it detects hypoglycemia at a very early stage, and it can be managed immediately, because hypoglycemia for a pregnant lady can be fatal both for herself and for the child. So early diagnosis before things get worse has to be done. And a lady has to be educated about the signs and symptoms and what to watch out for in case of hypoglycemia. What exactly could be the particular symptom that she could attribute to hypoglycemia, and check her blood sugar in case she doesn't have any constant glucose monitoring. Next, please. Next slide. Okay, so in insulin, again, teaching how to take the insulin is very important. The location of where she prick herself if the first time she's taking insulin in her life. So even that is very important. And in this particular event, insulin pen plays a very important role more than the pre-filled syringe. I usually prefer that the patient is taught how to use a insulin pen. It is very easy to use and very less painful, and the needles do not cause much of side effects or much of infections also, and if given properly in the proper sites, it is quite a painless technique. So this education is very important for to tell the patient about the insulin pens. Next please. Next slide. Okay, once the lady is diagnosed, we are into second and third trimester. And what is the points we should speak about in the labor and delivery? What is the safest method? People say early cesarean section would be an ideal thing to prevent complications, but no. The normal delivery would ideally actually help in getting out of the misery. If the lady is not going to labor or has any obstructed labor, then please do not wait and go in for a planned or a, if already the scan shows any kind of CPD abnormality or any kind of problem that could basically lead a complication in vaginal delivery, the highly recommended thing is to go in for a cesarean section at the earliest. Otherwise, please wait for a cesarean for a normal delivery to happen. But in case there are any signs of obstruction, immediately switch over to assisted delivery. Next, please. Next slide. Okay, what are the special precautions to be taken during labor? Pregnant ladies with GDM on insulin require plasma glucose monitoring, even during the labor by a glucometer. The morning dose of insulin should is withheld on the day of the induction of the labor and immediately given immediately given on 2 hourly monitoring of glucose. Immediately after giving this, after holding this, every 2 hour insulin has to be the blood sugar has to be monitored. And after that, once this lady goes into labor, IV infusion with normal saline is started and regular insulin is started according to the blood glucose level, which is being checked every 2 hours. But because she's not taking anything, she'll be nil for oral in the morning. So it's very important to withhold the insulin dose at that time. Next, please. All these things have to be carefully followed and uh, sought for during the labor. Next slide. Now, the complications of GDM. The complications of GDM, as I told you, are both maternal as well as fetal. So both the ways will have damage if this is not managed properly. Next slide. I'll just be listing out the maternal complications initially. Preeclampsia, very important and very common complication, if at all. I'll come to the questions a little later once I finish the presentation. Yeah, the preeclampsia is a very common complication of GTM if uncontrolled. Preeclampsia, as in the blood pressure will go up along with protein in the urine and swelling of the body. Next, please. Next slide. Obstructed labor. Unfortunately, as I told you, yes, if the lady is given a chance for a normal delivery, we can all have all possibility of obstructed labor if the gestational diabetes is not under control. Next slide. PPH and uterine atony. Uterine atony itself can precipitate gross PPH, and uterine atony also has to be diagnosed early for proper management and to prevent lethal complications. And unfortunately, uterine atony can be a complication of gestational diabetes mellitus, of course, if uncontrolled and not managed properly. Next slide, please. Next slide. Infections, sepsis, any kind of sepsis, the lady will be prone for hospital acquired infection, community acquired infection, both for herself and for her child. And she'll be at a very high risk of contracting any kind of infection. Next, please. That's about the maternal complications. What are the fetal complications of uncontrolled GDM? First and foremost, congenital malformation, as you can see, cleft palate and cleft lip on the left side. IUGR, or intrauterine growth retardation. This is unfortunately a very, very sorrowful sight to see. A mother delivering a IUGR child. It is really, it takes takes a lot of effort to get the child back to the normal, the normal weight for the age. So that's why it's very important at the third trimester, especially to control the blood sugar. Next, please. Next slide. Stillbirth and fetal macrosomia. The child can be that very small or very big, or unfortunately, we can also have stillbirths. Imagine having to endure the entire 9 months suffering with diabetes and getting out a stillborn child. This is the worst tragedy that can befall anyone. So please be very, very cautious about GTM. Early management is the key. Patient education is the key. It is very important for the lady to know her status of her sugar just before her labor days as well as during her pregnancy. Next, please. Next slide. Complications, even like neonatal jaundice can occur, pathological jaundice can occur, and shoulder dystocia, which is like the baby's anterior shoulder will get caught above the pubic bone of the mother during the delivery. This is most commonly seen in diabetic children because they are either very small or they are too big for normal delivery to happen smoothly. Why is early cesarean section not done? But yes, nowadays, if the GDM is uncontrolled and the lady is on insulin for a longer time, we are preferring to go in for an early cesarean section than giving a trial of a normal labor. But during normal labor, shoulder dystocia or the baby's shoulder being stuck with the mother's pubic bone is a very, very common complication during with a lady who has a GDM. Next, please. Next slide. Next slide. Yeah. Neonatal hypoglycemia. So this phenomenon, many people know, like basically the pediatricians are more aware of it, and hence, if a lady with GDM, of course nowadays all the pediatricians are there in the labor room, but if a lady with GDM is going in for normal delivery, it's very important to have a pediatric crash cart, a pediatric intensivist around during the delivery, as the child immediately after delivery can suffer from hypoglycemia. There can be signs like stupor, the child may not cry, uprolling of eyeballs, sweating profusely, cold peripheries, or even the child himself or herself might be cold. So they will have to check the sugar immediately and give dextrose and manage hypoglycemia within a few minutes. So it's ideal that a pediatric intensivist or trained pediatrician is there during the labor of a GDM lady. The next thing is sepsis. The sepsis, fetal sepsis, or ARDS of the fetus immediately after birth is also a known complication during GDM pregnancy. Next, please. Next slide. Okay, since we finished up to delivery, now prevention, everything is done. What is the post-delivery follow-up of a lady with GDM? As I told you, a lady with GDM can definitely have diabetes within 5 years. So a random checking of her sugars on and off, HbA1c every 3 months, 6 weeks postpartum doing her GTT is very, very important. And if her GTT is high, then keeping her at a high risk for or a high index for suspicion for type 2 diabetes and following up regularly is very important. It's definitely very important to follow up the lady frequently, because people who deliver this just say that it's done, and if the second sugar or the third sugar of the following day is normal, they forget about diabetes totally. It is not so. It is present. It is very important, and ideally this is the time for a correct management. If there's there's mishap during this management of post delivery follow up, then people definitely land up with type 2 diabetes all the life. Next, please. Next slide. As you can see, 6.2 million live births are affected by hyperglycemia and pregnancy, out of which 5.9 million are due to GDM. And this is the prevalence around 27.6% of whole over population of India. GDM prevalence rate, this is the prevalence rate you can see. In the urban area, 17.8%, semi-urban areas is around 13.8%, and rural areas, as we know, the activity is high, so around 9.9%. But again, I would step in at this point and say patient education is the key. Next, please. Next slide. So, what are the take home points in this entire discussion? Early detection is the key to prevent complications. High index of suspicion should be maintained for ladies prone for diabetes, like the one with a family history and who was obese with a BMI more than 30. Onset can be prevented by lifestyle modification. Whether it progresses to secondary type 2 diabetes or not, basically lies in the hand of the lady. It is how she manages her life well after the delivery, what kind of disciplined life and what kind of life she leads after the delivery definitely predicts the transformation of GDM into a type 2 diabetes. Again, I conclude by saying that patient education is the key for prevention as well as management. Thank you. Next slide. Next slide. We are open for Q&A. Devina?
Thank you, Dr. Haleema. That was a wonderful presentation, extremely helpful, learned so much. Now, I request the attendees, please feel free, ask any questions. We have a few in the chat box. Doctor, we can begin with those.
Sure.
The
Yeah.
first one here is Sakshi Kansal.
Yeah.
She is saying, kindly tell what should be the optimum sugar levels during pregnancy and when does a woman require to take it seriously and visit a doctor?
Visit a doctor should be as per schedule as a book patient who already does. There should be frequent visit to a doctor, especially if the lady has a background of family history of diabetes or early like pregnancy in the later stages, of the, later late 20s or early 30s, and if at all you have a very high family history of diabetes. Optimum sugar levels usually we take it up to 140 in home glucometer, but yes, very important to go in for glucose tolerance test. As I told you, glucose tolerance test, once it is done, the cutoff level is 190. So once after the GTT, if you observe any reading above 190, it is diagnosed as gestational diabetes mellitus, and a regular follow-up at this stage would highly be recommended. How to manage it? Again, as I told you, it is two things. There's lifestyle modification initially, followed by medicine if it doesn't work.
Ma'am, as you said 140, is it fasting or is it PP?
I'm talking about random sugar. Fasting is much less, 126. Fasting is around 126 and PP is 145. Random sugar somewhere around 140 is okay. But in diabetic ladies, we don't go in by the fasting random and home glucometer. We go in by the OGTT test, the glucose tolerance test.
Ma'am, home
So
glucometer is okay. Is it fine to use?
it is fine to use, but that's what I'm coming to that. It is not okay for diagnosis by home glucometer. The ideal diagnosis we do is by glucose tolerance test
And
for
ma'am,
any pregnant lady.
for monitoring it is okay, but for regular monitoring it is okay. But otherwise, we should go for a test. You are saying for
Yeah,
GTT.
yeah, yeah, GTT. GTT usually it is done for nowadays in every pregnancy because of the stress level and lifestyle changes. All the gynecologists are going in for a GTT in the second trimester. So
Okay, and
every pregnant lady is being looked for almost.
yeah, and ma'am, one more thing. If a woman is like I am diagnosed with gestational diabetes during the first trimester only, I have just started with my
Okay.
second trimester. So,
Okay.
are there any chances that it will, shoot up as the pregnancy will, move ahead,
Yes.
or uh,
It
or it will be
requires
managed?
constant monitoring. No, it can be managed, but it requires constant monitoring. If it is started early, as in the late in the first trimester and early second trimester, it is important to keep checking it frequently because this transition phase should have happened around second trimester and third trimester. If it started early, then I would say you could also have been having very mild degree of existing diabetes, which has not been checked. So it requires
Yeah,
all the more
might be
active
because
management.
during the very first test, I was diagnosed with diabetes during the
Oh, then
pregnancy.
it requires
You can
more
say as
aggressive
early as ninth week.
investigation. Okay, then it requires more aggressive investigations, timely follow-ups. That is the
Okay.
key. Okay, keep checking your blood
Oh,
sugar level, and if at all you feel uneasy any point in time, check it, record it, and tell your gynecologist or your diabetic person who's taking care of your diabetes. Okay,
okay. Okay.
so
Thank
both
you.
have to be involved in the management. Yeah,
Oh, okay, ma'am. Thank you. Thank you so much.
welcome. Next question, Devina.
Thank you, ma'am. The next question we have is from Stuti Mathur. She asks us,
Okay.
can a pregnant lady with GDM have a normal delivery or is it better to go for a C-section?
They can have a normal delivery, as I mentioned during my talk. They can definitely have a normal delivery, provided the sugars are under control and well managed, and provided there's no obstruction during the labor. If any time during the labor the obstetrician feels that the labor might be difficult or obstructed, better and safe to go in for a cesarean section. But yes,
All right.
vaginal delivery can be tried. Yes.
All right. She also says that pregnant lady in her first gestation had GDM. How much chances
Okay.
of there that she does
Okay.
not have second gestation or more?
Oh, definitely, definitely. There are chances, at least 50-50, I would say yes. It depends again on your lifestyle modification and how well you take your diet, how seriously you take your exercises, and de-stressing yourself. All these things are very important and the key for preventing GDM for the next time. So
Right.
eat right, eat on time, eat right, de-stress yourself, sleep 8 hours. Come what may, sleep for 8 hours a day if you are thinking of conceiving the second time. So have a very, very disciplined life, then going for the second child. And that time chances will be much less, definitely much less.
Thank
Great
you,
pointers
ma'am.
here.
Welcome.
Okay.
Next question.
Next is someone from Redmi Note 9 Pro. They are asking what is the sugar level for GDM fasting after lunch and after dinner?
Well, as I told you, it is random sugar around 140. After lunch, after dinner, we take it as a normal sugar. I mean, random sugar, that is around 140. That is a cutoff. But generally, we don't go by home glucose monitoring for the we go by glucose tolerance test. In that, 190 is the cutoff in
All
glucose
right.
tolerance.
All right. And she's also asking, please suggest the sugar level to maintain.
Uh, if you're going by home glucometer, definitely 120 to 130 as a random sugar. If you're going by HbA1c, it should not be more than 7. HbA1c will be managed, will be taken by lab, and that should be around 7. Usually we ask for that once in 3 months, but home glucometer is the acting to be tested for now for the stat sugar, and that should be somewhere between 120 to 130 milligram per deciliter for ideal control, which is very difficult to achieve with the stress and pregnancy. It is very difficult to achieve these readings, but that is the ideal reading to be maintained. Yes.
All right, doctor. Sakshi Kansal is asking, tell the rigor levels a woman should have during pregnancy.
Sorry, what levels?
My question is answered. My question is answered
Okay,
already. Yeah,
okay,
thank
okay,
you.
Sakshi.
Okay.
Okay, now we have Asha B asking us, how much time does a patient take to get her optimum level of glucose back after delivery? And are there
Immediately,
any
immediately.
chances?
It is almost like magic. Immediately. Once the child is out of the body, within 24 hours, in fact, within a few hours, the next sugar comes back to normal. In a typical GDM, it comes back to normal. If the lady has type 2 diabetes already, it takes time for control and management and all that. Yeah.
All right. And she's also asking, are there any chances of not getting her normal sugar levels back after delivery? Like she means that will gestational diabetes turn into diabetes lifelong?
Yes, 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 yes. It does happen. Again, that is in the hands of the patient. That is in the hand of the lady who is suffering. So once you know that you have GDM and it is gone after delivery, then there are chances of it turning into type 2 diabetes within 5 years. So you have a full 5 years time to change your lifestyle, to go more aggressive on weight management. and to kind of have a very very healthy lifestyle. So with this change in diet and change in lifestyle, it can be reverted, or it can be averted actually. So it is not necessary that you go into type 2 DM each time you have a GDM. But yes, lifestyle modification is the key. Avoid sweets, avoid refined sugar, especially if you've had a GDM, and going for low glycemic index food. I would say go very high on millets, go very high on oats. These food have very, very low glycemic index and very easy to digest. Yeah, and
That's
very low
right.
in calories. Yeah.
Yeah, the last question, ma'am. As we know that those who are suffering from diabetes, they have a slow wound healing time. So, what about the lady who is going for a C-section? How much time the wound will take to heal, ma'am?
No,
Is
usually
it
since you're on insulin for some time, in fact, if the sugar levels have not come to normal, we don't stop the insulin because the child will be feeding now. There'll be breastfeeding will be going on. So usually we do not stop the insulin immediately. So with the insulin, the sugars will come under control and wound will heal. But the thing will be that once we stop the insulin and all, if there's any other injury, yes, if you have type 2 DM, then that will be a different question. But during, and if at all your sugars are still high after your delivery, insulin will not be stopped. So that will help in wound healing also.
okay,
Yeah.
ma'am? Thank you so much.
Extra care will be required for the wound. Don't wet it frequently. Keep it dry and keep it clean. You will have, you have this. You can see this, sorry, swabs and all alcohol swabs. Keep wiping it frequently.
All right. So we have Dr.
Thank you so much.
Radhika Mangal. She's saying, ma'am, as you told that don't stop insulin after delivery, but IV suggest metformin after
Yeah,
delivery.
yeah. I mean to say, if the sugars are high after delivery also, and so high as to they require insulin, then we definitely ask them to continue that. And metformin is only safest oral hypoglycemic, even during the GDM, immediately after it also. So only these things, these two drugs are what are basically followed for the management of GDM pre and post. So yes, we do continue even metformin, and if the sugars are very high, despite all of that, we go in for insulin management also. You're welcome, Dr. Ravi.
Okay. To the audience, rest of the audience, do you have any questions? Please go ahead. Feel free. We'll give it a couple of minutes.
Ma'am, can you please tell a bit about that neonatal hypoglycemia? Are there any
Yeah.
chances that it will take a, I mean, like, will it take a tolerance on the child? Like, will it go for a lifelong term or like that?
Well, yes. What happens is neonatal hypoglycemia. It requires the doctor to investigate aggressively because the child will not be able to talk. Right? You will not know what is happening. There will be subtle signs like the child may have uprolling of the eyeball, the peripheries may be cold, the child may not cry, may be very stuporous, may be very drowsy. At this time, the sugar has to be checked from the toe. And once we know there is hypoglycemia, it has to be managed very immediately, because sometimes if managed immediately nothing will happen, but if there is delay, the brain can be affected to a certain extent. So that's why we basically recommend a very trained pediatrician if you're planning for a vaginal delivery for a GDM patient.
Thank you,
Yeah.
ma'am.
Yeah,
Ma'am,
if
one more,
managed,
ma'am.
nothing will happen. Yeah, please.
Ma'am, I have came across that term like hydroamniosis. In that, is it that the amniotic fluid get increased in the lady?
Yeah, it increases rapidly. I mean, so much so that there's no place for the child to grow. Yeah.
Why does it happen, ma'am? Why does it happen? Like,
Because of uncontrolled diabetes, there's water retention in the body. So water doesn't have any other place to go, especially in a pregnant lady, and gets accumulated in the amniotic fluid. And hence it goes on getting more and more. But if
okay,
sugar
ma'am.
gets under control, if it is managed well, it is well within normal limits.
Okay, ma'am. Thank you, ma'am.
Any other questions? All right. So, in conclusion, I'd like to thank each one of you for attending this webinar. Thank you, Dr. Haleema. It was extremely informative and this has benefited
Thank you,
all of us.
Haleema. Thank you,
And
Cartula.
I'd like you all know, I'd like you all to know that Cartula Health will continue these series with different topics discussed by industry experts. We have another chat. Thank you. Everyone is grateful as I am. All right. Thank you everyone for joining. Stay tuned. Stay safe. See you next time. Bye bye.
Bye.
Thank you. Thank you for the information.
Thank you for joining.